Welcome, my friends, to the Bob and Brad podcast. My name is Mike Keenitz, and today I'm interviewing Dr. Avi Bhar, who is a fellowship-trained and board-certified in sleep and pulmonary medicine. Today, we are going to be talking about insomnia specifically, causes and treatment options, and what he offers from his website as well. So without further ado, here is Dr. Bhar. Well, thank you, Dr. Bhar, for joining us again on this podcast today. So
Well,
you have
thanks
been
for having me again.
So last time we talked about sleep apnea specifically. So if you want to listen to that podcast, you can check it out. It was done over a year ago or so now. But today we are going to be discussing insomnia specifically. So before we get too far into this, would you mind telling us how you became interested in becoming a sleep medicine specialist?
So, good question. My background training is initially in internal medicine, which is hospital-based care in patients, and then I got interested in pulmonary medicine, and I did a fellowship in that. So, a lot of respiratory issues, and then I didn't feel like I had grown up enough yet, and wasn't ready to start working. So, my mentor suggested that I look into sleep medicine because a lot of our pulmonary or respiratory patients had issues with sleep. And I could be a better physician to them if I also understood sleep as an adjunct to everything else. Because if you have breathing problems during the day, it just kind of dovetails into breathing problems at night as well. So that's how I got into it. And I did not think I would like it this much, but man, I love it.
Wow. Yeah, it's kind of a, I think you really have to have a urge to do that if you want to get into sleep medicine.
Yeah.
So where
Mhm.
can people find you online?
So, on social media, you can look us out on Twitter or X or whatever it's called now, Facebook. You can come to our website. That's probably the safest bet. Come to us at sleep.com, SLIIP.com. And you can get more information there. You can figure out if you want to consult with us, shoot us a message, anything that we can do to help you.
So your practice is primarily telemedicine, correct?
Yes, it's all telemedicine.
So
And
you
so
work.
we're in 12 different states right now, and right from New York to Connecticut and Virginia to South Carolina, Georgia, Florida, Texas, Mississippi, Louisiana, Alabama, and Illinois.
And that primarily just works with people that are, if they're going to use insurance. Can you see people outside of those states if they're paying cash?
Both. So we still the law still are applicable whether you are in that state or not. So we have to have a license to practice in the state that you're residing in.
Sure.
And so but again, in the states that we are licensed to practice in, we can accept both cash and insurance. Some patients are lucky enough; they may have a family member in a state that we're in, and they use that as their address. So.
That works. No, it makes sense. Yeah, therapy is the same way. You have to be licensed per each state. So
It's
makes
the
sense.
and it's such a BS setup because I can understand lawyers needing to be credentialed in each different state because each different state has different laws. But I'm pretty sure if you cross the line from Missouri into Kansas, your sleep is still the same and the treatment is very much going to be the same.
Yeah, for the layperson, most of our exams are national boards, but then each state has a different requirement, so it gets a little
Mhm.
nuanced. Anyway, we digress from the subject at hand here. So, can you explain what insomnia is and how it's different from occasional sleeplessness?
So insomnia is actually any time that you can't fall asleep, can't stay asleep, you wake up earlier than you really want to. So any disruption in your sleep, basically, that you perceive. And insomnia is divided into the acute insomnia, which occurs generally within, in less than 3 months, and it's self-limiting, which means that it comes and goes, and it may be associated with grieving, or it may be associated with the exam coming up, or the fact that you have to pay a bill that's coming up that you decided to put in your credit card a few weeks ago. So all of these things can cause or add stress to your life and disrupt your sleep. So it definitely is, even being a caregiver to someone who's ill. So insomnia that then also translates into some sort of daytime consequence. Just having restless sleep or not sleeping well at night, but you feel great in the morning, you're doing that, that probably needs a little bit more. That doesn't really fall into the definition of insomnia. There has to be both the nighttime symptoms and the daytime consequences. And then it's divided into acute, which is that within 3 months, which is usually something that's self-limiting, something that's going to come and go, some new stressor that's going to pass as well. And then there's the chronic insomnia, which is where you really need to seek help, because if it persists or continues, there's something in your life that's stopping you from getting the quality of sleep that you need. And at that point, if you've tried over-the-counter medications, supplements, and so on, I would definitely recommend you to seek help, because sleep is such a vital part of how we function. I mean, it really sets the tone for the day. How you open your eyes and how you feel within the first few minutes really gives you an idea of how the day is going to be. And if we mess that up, it kind of sets the tone, and it's hard to kind of turn things around.
Yeah, I've noticed the older I get, I'm only in my mid-30s, but if I get less sleep, I'm just gonna have a rough day. It's just how it is, unfortunately.
It is. I mean, when you're younger, your body takes, alcohol is one of those things. Your hangover wasn't bad. I mean, I was like 3 beers in, I'm like, all right, I'm just getting started in my 20s. And now 3 beers in, I'm like, I'm going to feel this tomorrow.
Sure. So I'm assuming you maybe had some insomnia recently because we are trying to schedule this. You told me you recently had a child.
Yes, that's the acute insomnia, the less than 3 months. So she is healthy. She's 3 months old right now, gotten into a much better sleep cycle. So that's been helpful.
Yeah, I'd imagine. I don't have kids, but I've heard the stories. So, what are some common causes and triggers of the insomnia?
So it depends on your life and your lifestyle. One of the common ones that eventually come to us may be medication related. So some medications may have an unknown or lesser known side effect that might disrupt your sleep. Frequently, it may be related to things that actually are related to your health that may stop you from falling asleep or staying asleep. Things like aches and pains, or breathing or respiratory issues, chest discomfort, palpitations, things like that. These are all health effects or health issues that affect our ability to stay asleep and fall asleep and wake up feeling refreshed. So medications is one. Other health symptoms might affect your sleep as well. There's other sleep issues that may manifest as insomnia, whether it's restless legs, whether it is sleep apnea. These are some of conditions that might, even nightmares may disrupt your sleep. So that definitely is another thing. One that I find that I think people can kind of start making a changes is their scheduling of their sleep. One of the things we find is that people tend to, they recognize the fact that sleep is important, and they sometimes recognize they're not getting enough sleep. And so to respond to that, they actually increase the amount of sleep time or the time in bed, which intuitively seems fair. Oh, I'm investing more time in bed because I need my 8 hours. What they don't really see is the fact that when you're in bed longer than you need to be, that association of bed and sleep gets disconnected, and then sleep becomes a contentious issue. Like, why can't I sleep quickly? And what we find out is, in scheduling of your sleep, it's not the time you get into bed, and it is important but not critical. It is your wake up time that really sets the tone. And we call this social jet lag. So a lot of people may encounter this. I think most of us have had this effect, even with daylight savings time or even on a weekend. You shift your schedule a little bit, and you may stay up an hour or two later on a weekend, and then sleep in an hour or two. And so when you wake up on a Sunday at, let's say, 8 o'clock in the morning, and you usually go to bed at 10 o'clock at night, but Saturday night you stayed up till midnight, 1 o'clock. And so when you wake up at 8 o'clock, and when I say awake, I mean feet off the bed, light coming in or light switched on in your room, and really the stop clock starts. You've got 16 hours to stay awake, really. I mean, on average. Sometimes some of us get more tired mentally, more tired physically, sometimes both. So that 16 hours can change by a little bit, but generally 16 hours gives you the predictive value of saying, if I wake up at 8 o'clock in the morning, I'm going to likely be awake till midnight. But guess what happens? What we do, Sunday night comes around, and we have to get into bed early because we normally wake up at 6 to commute to work and so on. And then you have the trouble falling asleep. Because guess what? Your body's at 10 o'clock at night while you're in bed goes, hey, I've been only awake for 14 hours. What are you trying to do? Where the party at? And so, you have that effect. So that itself can cause difficulty falling asleep. and so then leads to symptoms of insomnia. So there's various factors involved, and kind of figuring out what's affecting you specifically is important. Kind of untangle that and then get treatment going so that you actually feel better and sleep better.
Yeah, I would agree with that. I didn't really think about that you more just wake up at the same time. It's not necessarily when you go to bed, but yeah, I pretty much stay in nowadays at night, but once in a great while, if I'm out and about for whatever reason, yeah, it's I still typically wake up the next day early and then I'm like, I wish I could sleep more.
Well, even if you want to sleep in, at least you know that night, that coming night, you might have issues. I think what affects us more is this an inability to kind of figure out why. Like, why am I having issues sleeping? I think once you are able to say, "Oh, this is why," okay, I feel like I have control of my sleep back again. Because when you're laying there and you're tossing and turning, you're like, "Why can't I sleep?" Guess what happens? Everyone says, "Oh, my mind won't shut down." Your mind won't shut down because it's not ready to shut down yet. I always, you're not special, sunshine. And it's not as like, my mind just won't stop working. So I was like, what sort of, are you trying to broker the Middle East deal? Like, I mean, what's keeping you up at 10 o'clock? And I'm like, why is your mind so important? And usually it's the scheduling of the sleep. And if you don't, you get into bed before you're truly ready or your body's ready for that, you are going to be awake. And guess what we do is that we then go, all right, I'm awake. Oh, I have to do this tomorrow. I have to do that tomorrow. What did he mean today when he said that? Oh my God, I still, I'm going to feel like ass in the morning, excuse my language. But, and so these sort of thoughts that start getting into our head actually take us further away from sleep. So,
Yeah, I think it's just in your I noticed when I used to be treating patients more, I always had to set my alarm in the morning. And I had to get up earlier than I do now for doing more social media stuff. But I felt like I got worse sleep because every time I'd wake up, I'd check what time it is when I did that. And now I don't set an alarm because I just kind of naturally wake up and start working. And I actually sleep better. I don't I think it's just a psychological thing,
no,
but
it is. That some of our behaviors to try to get better sleep actually can be counterproductive.
yeah. So, are there different types of insomnia and how do they differ? I know you mentioned acute insomnia, but are there different variations besides that?
Well, previously we used to associate insomnia and say that it was secondary to a health issue, secondary to this. But what we're finding is insomnia itself should be addressed separately. So it's not, oh, you have insomnia because you have anxiety. If we treat the anxiety, your insomnia will get better. We're finding actually it works both ways. There's a bidirectional connection. That means anxiety does affect sleep, but sleep can affect anxiety. So you have to treat both at the same time. So that's why the criteria for diagnosis has been simplified to just go acute, which we know kind of is life stressor, passing phase, and then you have the chronic, which I described, could be medication, could be health issues related, could be another medical condition, could be another sleep condition that might be affecting it. So that's how insomnia really is differentiated. And frequently, as a human being, as a layperson, whenever we're not sleeping well, we immediately think of insomnia. However, when we use the word insomnia, it is just at that point a symptom. And it's not truly a diagnosis. We have to figure out if there's all these other things, or medication or scheduling and all of this, is that a factor? And only once that's ruled out other contributing factor, then you say, okay, you still have issues with sleep. That's when insomnia becomes a diagnosis. Because if you use the word insomnia and you walk into a provider's office, and a provider meaning any doctor and so on, it doesn't usually not a non-sleep provider. When they hear insomnia, immediately the output is sleeping pills. But that's not the idea, is because we have to find out why a human being has a inability to perform something natural. Like if I told you, hey, you had an erectile dysfunction, or you couldn't get thirsty, or you didn't feel hunger, sex drive, thirst, hunger, sleep, these are all natural drives in our body. We all need them. We all get them automatically. The question has to be, I can prescribe you Viagra for erectile dysfunction, but am I missing out a cardiovascular issue that's contributing to this? So just treating the symptom itself doesn't really help us. It does paper over the cracks, and that's why some people do feel better with some sleep aids, whether it's over the counter versus actual prescribed medications, because it does reduce their awakenings at night. But many of them, if you ask them honestly, do you feel more refreshed in the morning? And the answer is no. So even though they feel like they're waking up less often, the outcome or the output and how they feel still remains the same. And that's when we have to figure out what is causing you not to feel refreshed, not for you to sleep well, despite you what seemingly should have helped you. If insomnia was a diagnosis and you got an insomnia medication to help you sleep, your symptoms should go away. You should feel better in the morning. You should sleep better. If you're just waking up less often, but you feel the same way in the morning, at that point, we have to take a deeper dive to figure out why. And because it's a natural drive, it's something that we have to figure out what's driving that problem.
Sure. So how does melatonin and magnesium play into roles with that? Can that help with insomnia at all? I know people often take them if they have sleeping issues, but
Yeah, so I think with the acute, melatonin really helps with acute insomnia. Whether it helps with chronic insomnia, it's very much specific to each patient. If I were to give melatonin to 100 people that have the exact same complaints, it won't work well for a large majority of patients, but it works really well for some patients. So it is, it definitely is something that if you're struggling for sleep and it's short term, and like I said, less than 3 months, and you want to use some melatonin because you're going through a project or you have some other issues at work or life, yeah, that's fine. Use that. But if you chronically need it, and that begs a question, why?
sure. Is
Magnesium
magnesium
as well works well. There's been some data out there, more anecdotal than randomized control trials, that have shown magnesium seems to have a positive effect on some patients' sleep quality. So we definitely are seeing that and some patients have tried that, and some patients of mine have tried without benefit. But I continue to try to figure out, what else can we do, because prescribed sleeping medications have a whole host of issues, and we're trying to figure out what's the best way for you to sleep, hopefully without the need for medications. And if you do need it, what's the least painful medication, the one with the least amount of side effects and effect on your health?
Sure. So how does insomnia affect age groups differently? So like children, adults, or elderly people?
Good question. So as we age, it goes back to that initial chronic insomnias. What is it caused by? As life happens, as we get older, we accumulate some other health issues. Those may become, so as you get older, definitely more of the insomnia complaints tend to be more prevalent as we get older. And again, we tend to use more medications as we get older. So definitely as we get older, we seem to have more of these symptoms of insomnia. Again, trying to figure out why. Again, most of us tend to have this idea that I'm expected to sleep poorly as I get older, and that's false. You should not expect that because I'm older I deserve poor sleep. No, you don't. Your sleep should be as good or nearly as good as what it were when you were younger, and that's what we're trying to figure out, is what's causing that disruption. So even if insomnia is a symptom that's largely in the older patient population, and when I say that, I see the white on my beard, and I know I'm falling into as well. So the irony is not lost on me. We have to kind of figure out, because I think a lot of times as we get older, the expectation is what changes our minds about whether we should seek treatment or not. And I think if you're not sleeping well and you're not waking up refreshed, you need help, especially in something that's been going on for more than 3 months.
Sure. Yeah, I remember we used to work in a lot of skilled nursing facilities, so primary elderly, and it seemed like the people that had extreme anxiety or dementia to a point were typically the ones with insomnia because they would sleep most of the day because they're up at night. But makes
Yeah,
sense.
and a lot of the heavy medications you do to treat anxiety and so on and dementia does add a level of fatigue on you that makes you more likely to have broken up sleep. So then you kind of have this irregular sleep wake cycle. You're taking an hour nap after lunch, or you take an hour nap in the late morning. So a lot of these medications then allow you to sleep during the daytimes when you should technically be awake, and that takes away from that credit in the bank that you need for sleep, because you're accumulating the debt of sleep, so to speak, as the day progresses. But if you then take a nap, that debt reduces, so that when 10 o'clock comes around, you're not ready for sleep yet. And as patients are struggling to get that, the best thing is that 8 hours or 7 to 8 hours of continuous sleep. That's way better than getting 3-4 hours here and 3-4 hours there. So there's a lot of benefit. And when you don't, that increases your risk of psychosis and so on, especially in patient populations at risk, like you say, with mental health and elderly.
So, Are there underlying medical conditions that commonly contribute to insomnia? I know we mentioned some of them, but are there more?
What I'm seeing in my practice is this. As I mentioned, a lot of sleep practitioners were grandfathered into sleep, and so they don't have a very strong background of actually being fellowship trained. So I was lucky that I was lucky. At that point I felt unlucky because I missed the boat. You could just, after doing pulmonary medicine sub training, the batch before me could literally sit for an additional sleep test and get their qualification to in sleep medicine. I had to give up another year of my life to go for a separate fellowship to do that. So I thought it was a bad thing, but now looking back, I'm glad I did, because a lot of the patients that we see are patients who actually have sleep apnea as the contributing cause of insomnia. And unfortunately, they go down the road of saying they have insomnia, and the provider doesn't know any better. And what they end up doing is putting them on sleeping pills, and they don't get any better. The other part to that is a lot of women use a different vocabulary, because who would have thought they're a little bit different than men? And their sleep apnea manifests a lot with fatigue. So, not really sleepiness. So, no one thinks of sleep as an issue. And then they don't really snore loudly or snore at all, which then puts them even in the thought of someone who's less sleep trained may say, okay, I don't think you have it. And then on top of it, they actually use the word insomnia more often to describe their sleep issues, while men tend to get turned in by the snoring police because we're louder, we're peacocks, and we want our attention. And we also tend to be more sleepy as an effect of that. So, there's a lot of patients, especially women who are normal sized, go through post-menopause, after menopause, and their sleep apnea risk actually increases threefold. And everyone tells them, oh, it's your hormonal imbalance, and they keep going on this hormonal cocktails, and they don't actually feel much better. And that a lot of it, I think, is driven by something else. And I think in that case, their insomnia is mistakenly being treated as such and not actually looking at things like sleep apnea. And sleep apnea is so subtle nowadays. The tests that we have are pretty much validated in a predominantly male, overweight, elderly population. So that test really sometimes underestimates or misses the diagnosis in patients who are a lot more subtle. And that can be men of normal size, that can be women normal size, younger people as well, because no one's thinking about it, because they associate the sort of poster child of sleep apnea, overweight person falling asleep in a waiting room or falling asleep while they're talking to you as a sleep apnea. And I call that the 5-year-old sleep apnea, because a 5-year-old can really diagnose that. But there's subtle things like, if you're grinding at night, that may be due to sleep apnea, even though you're not sleeping well. Waking up to urinate a couple of times at night, unless, of course, you're a 65-year-old guy with a prostate problem, you shouldn't be. Even night sweats. Night sweats are another common, now increasingly commonly recognized symptom of sleep apnea, because of the surges of our system when our breathing is not right. So we're seeing a lot of this disparate sort of like, oh, so you think night sweats, you think women going through menopause, but I have men as well of night sweats. Actually, night sweats is one of my symptoms for my sleep apnea. I would just wake up drenched, and as a pulmonologist, I was like thinking TB. Oh my God, I have TB and or tuberculosis. That's been drummed into, night sweats is drummed into our heads as the cause of that, but it wasn't. It was just my sleep apnea. So I think in the hands of a lesser trained provider, insomnia may just look like insomnia, and they stop looking for the underlying problem. Leg issues, leg movements, restless legs, because of our diet changes, sometimes because of medication use. A lot of leg issues like restless legs may also affect our sleep in a significant way. So thinking about that as a potential cause. So, sleep apnea is one, restless legs are another one as well. And that might be contributed. The restless legs may be due to low iron levels. And again, the iron levels are not what your regular iron levels should be. There's a much higher threshold to treat iron levels in someone that has restless legs as an issue. So even though your primary care may say, oh, your iron levels look fine, in the setting of restless legs, that needs to be looked at again, because the data shows that we need to get the iron levels at a much higher level in your bloodstream, because that iron needs to get into your brain, which is where it actually then treats the restless legs. But yeah, so just kind of giving you a couple of ideas of how else we're missing out on insomnia and what else it could be.
So We're going to digress a little bit into a different subject. So, how can screen time and digital devices affect insomnia?
So, it depends on how you're using screen time. Now, if you and again, I think most of the patients that come to us have already done their due diligence. No one just goes, "Oh, I didn't sleep well for the last 2 weeks. I'm going to go see a doctor." It's usually they've been struggling with it for a long time. They've gone online. They've looked to find ways. Whether it's blue light blockers, which again, just like melatonin, works for some, not for all. There's no silver bullet here. For some people, the idea of looking at their phone does have a significant effect on their ability to fall asleep pretty much immediately. Again, it depends. If you're using your phone at a time that you're not supposed to go to sleep, for example, let's say if your bedtime was supposed to be 11:30 and you're in bed by 10 o'clock, and you're like, "Oh, I looked at the phone at 10 o'clock and that's why I can't fall asleep." That's not necessarily true. The same way I would answer this question is if someone asks me, how does exercise affect sleep? Should I exercise before bedtime? Right? A lot of times that the understanding or the thought was, oh, if I exercise, it's gonna heighten up my I'm gonna be stimulated. I can't fall asleep. Well, maybe for some, not for all. So I would definitely encourage everyone to put their phones down at least an hour before bedtime, because there's more to life than looking at your phone. I've instituted that in my life. I do watch TV, but I'm trying to switch that to reading books as well, just because I find that peace of mind beforehand, that lack of anxiety of who said one on this, did someone reply to my text, isn't worth it. And I think for just overall peace of mind, putting their digital devices down, turning to that do not disturb sign, putting it on silent, all of these things can help, because I think overall it will kind of allow us to enjoy our peace of mind before sleep. Whether or not it has a direct effect on your ability to fall asleep, it's not truly known. For some people, like I said, you may be highly sensitive, just like caffeine as well. Some people are highly sensitive to it. For some people, you can drink it 2 hours before bedtime and you're good. For some people, the rule is about at least 4 hours or more. But what we're finding is in some patients, it can last for up to 6, 8 hours. And if you're older as well, and your liver isn't functioning the way it used to, the caffeine can hang around your system a lot more. So even a caffeinated drink at midday may affect your ability to fall asleep at 10. So it's all very nuanced and specific. So, but I think overall, less caffeine is better, and less devices at bedtime is also better.
Yeah, in my 20s, I used to kind of struggle with I'd get good night's sleep and then I'd have a crap night's sleep, and I just kind of alternate this cycle. And I did a lot of those things. I quit the caffeine like roughly midday or mid afternoon, but I feel like the screen time, it's not like the screens or the blue light. I feel like it's how engaged you are and what you're doing on it. So it's like you're scrolling through something. If I'm watching unfortunately, right now I'm a Timberwolves fan and they're on these 9 p.m. start games. So I'm staying up late engaged watching that. And it's like I stay up, but if it's like I'm just watching something I don't care about, I pass out, no problem. So
Mhm.
I feel like it's, yeah, the amount of engagement.
Yeah, no, that definitely is true. Like if you're just scrolling through mindlessly, that's different compared to like, oh my God, what's going to happen next?
Yeah. So I also noticed, so like whenever I go camping, I'm typically a tent person still. I'm in bed by 10 and I'm out. Like cuz it's like sure I may have my phone with me, but it's like there's just less engaging stuff out there at night, versus home you can get so distracted.
Well, and also don't forget when you're hiking, you're exerting your physical. That's why exercise is such an important part of sleep. If you can do that and incorporate that, the physical draining activity like hiking and so on will allow you to sleep better. And that's why exercise, drinking enough fluids and exercising is all part of a natural or a healthy lifestyle. So definitely recommend that as an adjunct to help you sleep.
Sure. So, how does stress and mental health play a role in insomnia? I know we talked about anxiety a little, but are there other things?
One of it is the medication effect. Some of these medications that are used to treat anxiety and so on, and depression may have an effect of stimulating us. And some of the medications actually have a kind of a mellowing effect. And so if it stimulates us and you take that close to bedtime, obviously that stops you from being able to fall asleep. If it mellows you out, it might actually cause you to kind of be more fatigued during the daytime. So you don't do much, you stay indoors, and so you don't exert yourself as much. So that could also have a negative effect on your ability to fall asleep at night. But medications are one of the most common reasons why someone with mental health issues may not. But then again, it also comes down to the things, simple things like sleep scheduling, to making sure that you make sure that you're able to wake up at the same time. Because some of the medications they take for mental health issues might cause them sluggishness or a hangover effect in the morning. So they tend to sleep in, and their wake sleep time kind of keeps shifting back and forth. But then we also know now that that's why I was talking about the insomnia as a diagnosis, a standalone diagnosis versus associated with another medical condition. We find that that's less useful now because we understand that if you have mental health issues and you have sleep issues as well, we find they feed off each other. And if you don't treat both at the same time, you tend to have problems. But anxiety as well, because if you're an anxious person, what tends to happen if you get into bed at 10 o'clock and you're not falling asleep, the first thing goes off is, holy crap, it's going to be one of those nights again. Why Mike? Why me? Why am I? Why can't my wife? She hits the pillow and she's already sleeping. Why me? And so that increases your anxiety and angst as well. So I definitely think there's more to it than just mental health, is because it could be medication effect, it could be your scheduling, it could be the fact that we need to treat your sleep issues concurrently to your anxiety or your mental health issues.
Sure. So, what are some common misconceptions about insomnia?
That you need medications to treat that. I think short term, it works really well because you just need to get over this period of difficulty or whatever stress in your life right now. I think a sleep aid works fine in those situations. Just be cautious about sleep aids and their hangover effect. And sleep aids, I'm talking about both over the counter and prescribed. They do have a hangover effect. So if you are starting or taking it for the first time, make sure you try to do it if you can, possibly on a weekend, so you're not waking up and commuting to work immediately and not understanding how your reflexes may change and so on. But start at a lower dose. A lot of times as well, CBD, if it's available, may be a good option for some states that have legalized it. The side effect profile may be better. It doesn't interact as much. So I do think in terms of insomnia, that's one of the pit holes, is that you say that and immediately you think you need medications to treat that. Not necessarily, but in the right setting, especially in acute insomnia, I think it works well. In chronic, you definitely need to seek help. And again, make sure that you have someone that's really evaluating you, that's on your side, to kind of get to the bottom of why you're not sleeping well. And a quick reflex action in terms of, this is when you go to your primary care doctor's visit, and you're there for 10 minutes and 8 minutes of it is, hi, how are you doing? High blood pressure medications, your diabetes medications, your thyroid medications. And then, I'm not sleeping well, by the way. Okay, here's an Ambien, boom. And as you're walking out the door. And that's what you don't want to get into, because it builds dependence. And you actually have a tolerance, and then you also then have a dependence in the fact that when you stop these medications, you also go through like a withdrawal period. So, I think they work well short term, but you really need a good partner on your side to figure out, is your insomnia a diagnosis or is that a symptom? And someone needs to help you figure that out. So I think that's the biggest misconception, is the insomnia as a diagnosis and a symptom. If it's a diagnosis, means that you've already ruled out all these other factors. You've done your due diligence with the patient, and then you can say, okay, we should go ahead and treat this with medications, versus that being the first reflex action. And again, I'm speaking about chronic insomnia. In acute insomnia, it's treated a little differently because it's usually a passing phase, usually.
I'm presuming it doesn't affect it, because I remember I asked you on the sleep apnea podcast, but does nicotine have an effect on insomnia?
Yes, it can. It actually, so a lot of the data works on both sides. Nicotine can sometimes disrupt your sleep, but someone who's trying to stop quitting or quit smoking, the lack of nicotine can also kind of keep them up a little bit as well. Generally, you want to stay away from smoking too close to bedtime. It basically is the same thing with having a large meal before bedtime. If you do, I mean, obviously, the recommendation is to quit smoking. But if you can't, then don't do it anywhere close to bedtime, because that may have a negative effect. Or don't wake up in the middle of the night and go, I feel kind of awake, let me go grab a puff. Not a good recommendation on that one. So I wouldn't do that. So it does have an effect. For some people, they can be very sensitive to it. For some people, they still can sleep through the night, but it does have a disruptive effect on their sleep.
Sure. So I know we've mentioned many of these. I guess you can lump them all together, but what are the key lifestyle changes or habits people can incorporate to alleviate insomnia symptoms?
So yeah, I'm glad you used the word symptoms because that's definitely what it is. It's a symptom until proven otherwise. One of the things you can do is, like you said, just the simple thing that I find that really empowers most patients is knowing that their ability to sleep hasn't been lost. They all have the innate ability. We just need to figure out what's going on. And the first things they can do to help themselves is to wake up at the same time every morning. Just start doing that more consistently. And someone may say, oh, why, I want to sleep in a little bit more on a weekend. Some days I have to drop my child at school, so I have to wake up early. Can I sleep in on other days? And my response to that is like, yes, I understand that you feel bad that you can't have cake every day if you're diabetic. But if you're not diabetic, then you're lucky. Then good, you can kind of be a little bit more adventurous. But if you have an issue that you're dealing with, we have to be strict with the treatment. And that's why the idea is to stay off medications. And the first things you can do to get your sleep wake cycle back, or the predictability of it, where you feel like you're more in control, is knowing the 16 to 8 hour rule, where you wake up at the same time every morning. You can fast forward that clock 16 hours, and you can more or less anticipate when you should be sleepy or feeling asleep, like you're tired and ready for bed. So that gives you first the insight into why you may not fall asleep or what's going on with your life. Then obviously the things that I mentioned, which is don't have a large meal close to bedtime, nicotine. If exercise affects you close to bedtime, then do it at least 3 to 4 hours before bedtime. Now, I'm not discouraging exercise, because I know some people still work out at 9 or 10 at night and they go to bed by 10 or 11 o'clock. And so, this is not a blanket statement. Everyone's a little bit different how sensitive they are. Energy drinks are also another common factor. Anything that's caffeinated, even if it's tea, and even though it's mild tea, if it has caffeine, the only way you'll know is to stop it at least 6 to 8 hours beforehand to see whether it has an effect on your ability to fall asleep and stay asleep. Screen time as well. Again, you have to kind of run these experiments on your own, and it's so easy to do it. It's just do these things a week at a time. Like, I'm going to stop caffeine at noon. I'm going to see how I sleep. All right, good. And then next week, I am going to make sure I have dinner at least 4 hours, because I keep waking up and feeling I'm like indigestion. So depending on some of the symptoms, do that, and kind of experiment. All you need is a week at a time, roughly, to kind of see whether a day or two may not give you the data back to say that you make a conclusive judgment on whether that has affected. So I'd say give it a week at a time while you're trying or experimenting on some of these changes to your life.
I'm presuming if you're struggling to stick to a sleep schedule, if you have a child like you did, it gets you in a routine pretty quick, huh?
Yes, you're
I
in survival mode. And they always say, when you have a child, a young baby, it's always good to sleep when the baby sleeps, and that's what you have to do. And all bets are off during the first 3 months.
Yeah, we have pets at my house, and unfortunately, they're all used to my girlfriend's early work schedule for being fed in the morning. So they let us know every day when we need to get up. Unfortunately,
Well, they try and tell you to go to bed a little earlier.
I guess that it's worse when daylight savings kicks in. Oh my gosh, I'm glad that's over now.
Well, that's true. And then the Timberwolves as well.
Yeah, that animal too. So, what are some effective non-medication based treatments for insomnia?
So non-medication, like I mentioned, I think the sleep scheduling is probably the most powerful tool that you can. A lot of times, just mindfulness is really helpful, clearing out the head, because when you get into bed and trying to do a checklist of all the things you need to do today, or you should have done today and tomorrow, is not really beneficial. So trying to kind of do deep breathing exercises does take us away from that sort of higher stimulation state. Kind of stimulates the vagus nerve, brings in the relaxation nervous system called the parasympathetic nervous system. So taking those deep breaths, and that's why even when you're struggling for sleep at night, just trying to you just focus on your breathing, just take deep breaths. Some people like counting sheep, some people like counting, and 1, 2, 3, 4. I find that really distracting because at some point I lose track and I'm like, oh crap, Avi, you can't even count past 19, and that's how self-talk is not going to help at 10:30 at night. So I just keep it simple. I just do deep breathing, in and out, in and out. Your mind will wander. Don't react to that. You're expecting your mind to wander. You may, I'm breathing, and I have to do that tomorrow. I have to go to the bank. Oh, Avi, all right, bring it back. And then keep breathing, keep breathing. Mind wanders, keep bringing it back. And guess what? It is monotonous enough and relaxes you enough that you will eventually sleep. Just stick to it, but don't get angry at the fact that you haven't slept yet. It will slowly kick in. Just keep bringing your mind back and not reacting, because the last thing you want is your pulse to start increasing, you getting more agitated. So the other thing I recommend to most patients is if they're not asleep by 15 to 20 minutes and they don't think they're ready for bed yet, get out of bed, do something relaxing, read a book, don't watch the Timberwolves play. And then when they're ready for bed, come back into bed again. The deep breathing exercises works really well. Keep it simple. And without, there's a lot of these tools online on Instagram and everything else. Oh, you should do this and that. Sleep isn't complicated. Sleep isn't expensive. You don't need an expensive cure for that. You just need to figure out what's going on and have that treated. When I mean by expensive, I mean like you don't need to buy a super expensive mattress. You don't need to buy silk bed sheets. You don't need to have a super expensive pillow. It's such a natural process that you will have it in and out. And if it becomes a complicated process, like you have to jerry rig your room and do all this crazy stuff, there might be something else at play, and you should seek help for that.
So when people fall asleep, I know I didn't put this in my questions, but I notice personally, like certain positions will make me fall asleep faster than others. Is that a common thing?
Some people have a propensity from they like one side. Like I like sleeping on my sides, for example, but there's also something more to it. Some people like sleeping on their belly. And usually what we find is, most patients like sleeping on their belly because when you sleep on your stomach, for example, it actually compresses on your chest and your natural chest expansion gets affected. So you're like wondering, why would someone sleep in that position when it obviously affects their breathing or the chest wall? But what you find is if you have breathing issues in your sleep, when you sleep with your belly down or your stomach down, your jaw falls forward, which keeps your airway open. So that helps you breathe at night. So a lot of patients with sleep apnea, they were like, oh, I love sleeping on my belly. I don't know how I'm going to ever adapt to treatment with sleep apnea. The reason why they're sleeping on their belly is because same thing with on their back. Some people with bad sleep apnea can't sleep on their back because of the gravity effect on their tongue and the jaw moving backwards, narrowing their airway even more. So definitely some positions may actually cause you to have less ability to fall asleep because of your breathing issues. But going back to your other health conditions that we talked about, like when you're older and so on, you may have aches and pains in different parts of your body, and your body just naturally gravitates to the most comfortable position. So definitely that as a factor in terms of position does help. Now find whatever position works for you that gives you the best quality of sleep.
Sure. I start like on my back and then I go side and then sometimes I end up on my stomach. And I had this preconceived notion in my head when I was a child, you were supposed to put your baby on their stomach to sleep because they were worried about, babies vomiting on their back and choking on it. But now it's, totally different. Here I thought it
Literally
was just
80
because of that.
degrees. Yeah, and a lot of it is because they think that some of the issues were due to breathing issues because they got smothered and so on when they were sleeping. So, yeah, definitely for babies is sleep. Put them on their backs for sure.
Sure. I thought that's why I slept on my stomach though, because I was always put on my stomach.
We blame our parents for a lot of things. That's not one of their faults.
I used to sleep with sunglasses on too when I was a child. Apparently, I don't do that anymore though. Don't know where that came from.
Well, you were way ahead of the blue light blocking craze.
I guess. So can you discuss the role of cognitive behavioral therapy for insomnia and treating chronic sleeping difficulties?
Yeah, so in patients with chronic insomnia, and they've ruled out other causes, so they've kind of gone through the whole process of getting to insomnia as a diagnosis. CBTI, or cognitive behavioral therapy for insomnia, is magic. I say that because it works so well. It works even better than sleeping pills. that more people should be trying it. And it really isn't rocket science. It is kind of part of it is what I basically went through in a very brief way about the sleep scheduling, about things related to when you fall asleep, the lights, devices, activity. And then it comes down to some of your thought process, some of the misguided ideas that you have about sleep. I need to have my 8 hours sleep. That's why I go to bed at 8 o'clock, because I never get 8 hours sleep. That's the only way I get 8 hours of sleep before the sun rises at 6, by getting into bed at 8 o'clock. Some of these ideas. So we have to untangle all of that, figure out like, something set this off, and then it slowly transpired over years to this earlier and earlier bedtime. So kind of unfolding a lot of that to kind of challenge some of our ideas about what it is. So, even the sleep restriction, which is a subset of CBTI, is where you don't get into bed until you're sleepy. Some of us get into bed when our partners get into bed because, hey, it's socially accepted. My partner gets into bed by 10. I need to get into bed at 10. Now, it's fine if you and your partner fall asleep around the same time. But if you're not falling asleep and you're struggling there and you're going, damn, partner, you're already asleep and I'm awake, and that kind of increases anxiety, then you kind of figure out that at that point, that might not be the best sleep time for you. And you may need to take yourself out of that bedroom environment and bring yourself back in. So sleep restriction is also part of CBTI. So, and if you find a good therapist, there are many online now that you can work with. Our practice does that as well, but not to the extent of a full therapist and someone who's trained to do this and does this only. We do a brief version of that. So if there's anyone that needs further than that, we will make a referral for CBTI. But we attempt a lot of that with our patients as well, just teaching them the tools of what they need. But it's definitely something that, especially if you're someone that is on sleeping pills or has been on sleeping pills, you felt that you've already gone the due diligence workup that was done, and now we need to kind of figure out how to get you off sleeping pills. CBTI works really well.
So, is there anything else you do in your practice specifically that's different with treating insomnia?
So no, I think we do everything we're supposed to do well. We listen to our patients. We try to avoid reflex actions. So, insomnia, I have to do this. I have to get you on medications. No, it's an open conversation about what's going on, what your actual sleep issues are, because understanding the term that a patient uses may not be the medically defined term for it. And then trying to make sure that we don't kind of fall into that, okay, you have insomnia, you're not sleeping well, here's a medication. It's not about trying to figure out what chemical is going to knock you out. The first step is to find out why you can't naturally fall asleep. What is going on? What is the blocker? So that process has to take place with a good partner, someone that's willing to listen to you, not someone that just wants to order tests or order medications for you, but actually is working with you to make sure that you have your issues addressed. Because each one of us is unique in our experience and the pathway or what is affecting us. Because even if two exact people have sleep apnea or insomnia, the words that they use or how much it affects their life differs greatly. So each one of us is unique, and trying to figure out what is causing that issue is the first step. And there's no silver bullet. We just have to have someone that actually gives a shit about you. Excuse my language. and we do give a shit.
So my last question is, are there any new emerging treatments or technologies to help manage insomnia?
Yes. And so there's a lot more data now, especially in patients who have chronic insomnia and patients who are very resistant to sleep, even despite going through the workup and getting tried on different medications, patients who do truly struggle with insomnia. There are newer medications out nowadays that actually do allow sleep that's more effective. You're able to fall asleep, and fewer side effects in the morning where you wake up with the grogginess and so on. So there's many newer drugs out there that help us stay asleep, fall asleep, and so that's definitely one that's promising. The other thing is a lot of it is brain stimulation as well. There's a lot of these sort of new age treatments that are looking into how do we stimulate the brain to shut down, unwind, kind of reducing some of the anxiety centers as well. But again, these are in patients who really have not just insomnia, but usually they have other sort of treatment-resistant mental health issues as well. And so the transcutaneous stimulation does have a positive effect on sleep as well.
Well, thank you so much for joining us today. Do you mind mentioning your website again?
Yeah, it's sleep.com. It's pronounced sleep as you normally do, but it's pronounced with three, it's spelled with three I's and .com. So come to the website, check it out, share it with someone that you feel, even if you don't have the problem, share it out or help a friend out and forward that to them. But if you just want to ask us a question, if you're currently being treated and you're not sure whether we are able to add value, just send us a message from our website and contact us page, and we'll be happy to kind of figure out if we're a good fit for you as well.
Is there anything I forgot that you would like to mention?
No, I think we kind of covered a lot of the core functions. I think one of the things is sleep is essential, sleep is natural, sleep is not expensive, sleep doesn't require medications necessarily, and as long as you do your due diligence and you have your awareness of your sleep affecting your quality of life, reach out. We're happy to help.